Hello and welcome to another Piper Pearl. Today's Pearl we're going to be looking at the sore throat. Now I completely understand that sore throat isn't a diagnosis, it's a symptom. So today we're going to be looking at a few common disorders that all involve a sore throat and looking at tips and tricks to know what pathological pathway the sore throat has probably taken and how best to manage it, okay, whether antibiotics are the best choice, whether we need to escalate it because we believe it's quinsy or Epstein-Barr, and basically just a good way to conduct a solid examination on somebody that has a sore throat. But like always, we'll start with a few facts to break down the umbrella term. So when we're looking at the sore throat, the etiology of sore throats, which is commonly called pharyngitis, about 50 to 80% of all of them have viral origins. And a lot of the viruses come from the same viruses that cause the common cold as well. And there's a particular virus that we need to look out for, which is the Epstein-Barr virus. It's a very important consideration, but it only constitutes about 2% of adults with a sore throat. And it's that 15-year to 25-year mark that is quite peaked for that area. Now, bacterial infections are most likely caused by a very famous bacteria called the group A beta hemolytic staphylococci, or strep throat, as you may have heard of it, or group A strep. Now, this is the same bacteria that's been linked to causing acute rheumatic fever and also strep glomerulonephritis and a bunch of other disorders as well. So it's one to look out for. And depending on the studies and the areas that you look at, it causes about 5 to 36% of all sore throats is caused by this group A strep itself. When we're looking at bacterial infections, they are very, very common in children between the ages of 5 and 15, which surprisingly is the link to what acute rheumatic fever is very common as well, 5 to 15. It's rare in adults all the way up to the age of 45, and then from the age of 45, the probability of getting a bacterial pharyngitis, tonsillitis, things like that, is actually quite low. There's a significant drop-off from the age of 45 all the way through the rest of your life. The use of antibiotics needs to be based on a good clinical assessment. So you're going to meet a few criteria before you give antibiotics, unless that person is at high risk of acute rheumatic fever, and then they're more likely to get it. Now, people who are high risk of acute rheumatic fever, being in Australia, we like to lump it in as basically high risk is Aboriginal and Torres Strait Islanders, but the results are still out. Whilst Aboriginal and Torres Strait Islanders are still absolutely at risk of acute rheumatic fever, all the evidence worldwide suggests that it's mostly got to do with living conditions, communal living, things like that, as opposed to a genetic predisposition based on race. So they're doing more testing to see if there is a gene link, but right now the high risks are associated mostly with communal livings. So it's very common in school, 5 to 15. So if you think of it like impetigo or like any infection where strep can spread, means that the people are at risk of acute rheumatic fever. Anyone who's had acute rheumatic fever in the past is considered significantly high risk of it, and they're more likely to get prophylactic antibiotics for a sore throat than someone who hasn't. Because we're looking at a sore throat as an umbrella term, we'll just spend a bit of time defining a few definitions. So pharyngitis is obviously inflammation of the pharynx, and this is really what the technical term for a sore throat is. And even pharyngitis itself is an umbrella term for most of the other disorders. So Epstein-Barr, tonsillitis, quinsy, they'll have componentry of pharyngitis with it. Other things besides pathogens can cause pharyngitis. The most common cause for pharyngitis is virus, but it can also be irritants, smoke inhalation, loud talking, things like that. But the loud screaming and all the rest of it is mostly linked to a sister condition called laryngitis. Now, this is simply similar etiologies, but associated with inflammation of the larynx itself. This is where you get hoarse throat or lose your voice. Now, this can also be caused by esophageal reflux disease, and even just normal everyday reflux as well can cause laryngitis, as well as the other viruses, bacteria that can cause your pharyngitis. When we start looking at tonsillitis, it's like pharyngitis, has similar pathogens that can cause it, but it's more associated and housing in the tonsils, causing them to swell. And when the tonsils swell, we obviously get that marked appearance of tonsillar bed enlargement, and that's when it leads into tonsillitis. When we start looking at quinsy, it's like tonsillitis, but instead of just a general infestation of a pathogen in the tonsils, it's associated with a large abscess, and it causes the actual area within the mouth to shift. So a good clinical sign for quinsy, as opposed to tonsillitis, is you'll actually see the uvula, it's a little punching bag in the back of the throat, has actually shifted to the left or right, or away from the actual abscess itself, because the pressure that's forming inside that tonsil bed from an abscess is actually causing the whole pharynx region to alter and the periotonsil area to swell and displace. Now, quinsy can be a medical emergency because of airway occlusion, so it's definitely one to watch out for. And then we have Epstein-Barr mononucleosis, which was coined back in the 1920s because it's when they distinguished the difference between pharyngitis and Epstein-Barr, because it was affecting a whole bunch of children in a school. And when their blood work was looked at under a microscope, they noticed that the lymphocytes actually went through lymphocytosis, which means the nucleus within it actually became a mononucleus, hence the name, mononucleosis. So it actually alters the lymphocytes themselves, and it travels through the lymphatic tissue. Now, Epstein-Barr is actually a herpes virus, so it's one of those ones that once you get Epstein-Barr, or mononucleosis, or glandular fever, or the kissing disease, depending on what you've learned it as, then it's actually with you for life. Okay, just like all other herpes. Once you get herpes, they're with you for life, and it has reoccurring stages throughout your life based on immunocompromise. So it's definitely one to watch out for, and we'll look more into Epstein-Barr as we go through the examination process. So starting all good examinations, we always start with our subjective investigations, and I like to use EPSAM. You don't have to, obviously, but we always start with the event. And when we're dealing with the event, we're mostly looking for those other symptoms, really. So an event way is a good way to rule out any environmental factors. They're exposed to chemicals, they're exposed to smoke, they've been to a concert, whatever it may be, we can rule those ones out. Then we start getting associated symptoms, and we focused on the minor viral infections first, and then we look for clues that there could be something worse. So if we're dealing with pharyngitis, pharyngitis is usually associated with other symptoms around the coryzal region. So you have your rhinorrhea, you have your dry cough, and you'll have your sore throat as well. A fever sometimes, but not always. Tonsillitis, we start moving away from those coryzal symptoms if it's more likely to be bacteria. And we have the sometimes difficult swallowing and more focus on that sore throat and not many other associated symptoms. When you're dealing with Epstein-Barr, then you'll have a sore throat, definitely. You'll have a fever, and you'll probably have pain in the neck as well, and you'll have general fatigue associated with it also. Okay, so you just listen out for those clues, and if it's viral, sounds like a cold, then it's most likely going to be a viral infection. But if they start describing other features, like dysphagia, anything like that, then you can definitely know that when you look in the throat, you're probably going to find some sort of obstruction in the back of the pharynx. When we look at our previous history, we need to ask questions about their current illnesses, because if they've had this sore throat for a while, then it's more likely progressed into bacteria. If they've had this particular infection and have taken antibiotics or anything like that, then definitely a red flag that we need to look out for. If we're thinking that it's bacterial and they have tonsillitis, then you'll often have to ask a sexual history after you've thought about tonsillitis as the diagnosis, because your chlamydia and gonorrhea and other STIs can actually cause your tonsillitis as well, as opposed to just your group A. So just keep that in the back of your mind. Tonsillitis is classic for reoccurring cases, and a lot of the time those reoccurring patterns are often used in a surgical consult to see if a tonsillectomy is warranted. When you're dealing with viral infections, you think it's more likely pharyngitis or tonsillitis caused by a cold, rhinovirus, anything like that, you need to ask if they suffer from any respiratory conditions, in particular asthma. But they're the big ones for the previous history. When we move into subjective questioning, it's a good idea to get the patient to pinpoint their pain, because we need to know whether or not the pain is associated with the throat or with the neck itself. If it's associated with the neck, then we do a whole other investigation, not really looking at any throat pathogen, but we look at things like profound lymphadenopathy, any salivary glands inflamed, things like that. The focus becomes on the neck as opposed to on the back of the throat. We also need, just for our holistic management of the case, we need to know how it affects the person's life. If they're just dealing with a bit of sore throat and pain, something that a simple analgesia and lozenge will deal with, then that's not too bad. But if it has associated malaise, fogginess, anything that's debilitating, then we need to take that into account. Allergies are relevant with medication and also can have a link towards starting with your allergic rhinosinusitis, moving into common cold, moving into pharyngitis, just a normal sort of history of pattern, because you can get pharyngitis from postnasal drip that is caused by nothing more than allergic rhinosinusitis. So it's a good one to rule out. Medications, as mentioned, have they been on antibiotics already? And what other medications have they taken? Much the same as overuse of oxymethylzolene, overuse of antihistamines, can have a rebound effect to nasal congestion, leading to postnasal drip, leading to pharyngitis. So it's just finding links of those causes just to paint a picture. But that's pretty much it for subjective information. A lot of the findings and differentials will come from actual objective investigation, which we'll look at now. So we always do a vital sign. Bacteria is more likely to cause a fever, but it's not a definitive diagnostic. So bacterial tonsillitis and Epstein-Barr, so there you go, I just lied to myself, are more likely to cause a fever. So if you're trying to weigh up between viral or bacterial pharyngitis or tonsillitis, a fever can be a good indicator, especially a reoccurring fever, okay, but not a definitive by itself. So do your vital signs, look for signs of compensatory. There is a link associated with Epstein-Barr and compensatory shock, mostly got to do with splenomegalia, that we'll look at, and that can be an absolute red flag, as it always is. So if someone's not hemodynamically stable, then massive red flag obviously comes into play. We always check their lymph nodes. Lymph nodes are quite interesting and quite helpful for us. So when we're dealing with pharyngitis and tonsillitis, it's mostly the anterior lymph glands that will be inflamed. So they're the ones forward of the sternocleidomastoid itself. Okay, so the submandibular, the tonsillar, those sort of ones. But when we're dealing with Epstein-Barr, we mostly have our posterior lymph glands inflamed. Okay, so you've got to get used to examining not just the ones under the chin and down the front of the neck next to the trachea, but actual ones that are associated with the posterior area of the neck. Now, I plan to do another lesson that just looks at doing a proper examination on lymphadenopathy, so look out for that one in the future. It is always a good idea to look for associated symptoms of any ear problems. You can have otitis media as well as tonsillitis because you have a blocking of the eustachian tube. So always have a look in their ears to see if there's anything contributing, and check their sinuses too, because if you have a large blocked sinus, again, it can cause you postnasal drip. The infection can travel down, causing that irritation. Now, Candidiasis is an interesting one, and sometimes it's caused purely by somebody taking antibiotics or something like that. But generally speaking, in adults, we don't get Candidiasis easily because we have a nice bacterial flora in our mouth. So if you do, then it can be associated with an early sign of having diabetes or being immunocompromised. So if you're looking in the mouth and the sore throat is caused by Candidiasis in adults, then just do a bigger investigation than just going, okay, you've got Candidiasis. It's not as mundane as people may think. Associated maculopapular rash can be seen in mononucleosis, but it's almost guaranteed if someone gives amoxicillin to someone with Epstein-Barr, thinking it's bacterial tonsillitis, which is an easy mistake to make, don't get me wrong, but they will often come back with a rash, and that rash happens in 90 to 100% of the cases of people with Epstein-Barr who have been given amoxicillin. Now, I'm no way suggesting that that can be your test to see if it's different, because the rash can actually be quite dangerous and quite irritating as well. If you think you're dealing with Epstein-Barr, then it's a good idea to just have a check of the spleen, or at least note that the spleen could be enlarged. So if you're not comfortable palpating or percussing the spleen to check for splenomegaly, that's fine, because really an ultrasound to tell us whether or not it is a good idea. But 50% of people with Epstein-Barr will actually have splenomegaly, and they'll be at high risk when dealing with contact sports or jobs that involve some sort of high impact contact. Okay, so just really be aware of that. Remember, Epstein-Barr travels in the lymphatic system, causes splenomegaly, and can even cause hepatomegaly as well. As far as other testing goes, pathogen investigations, we have the use of the swab. So not everyone needs a swab, and depending where you work, they'll have strong rules associated with using swabs or not using swabs. So the data is all over the place on swabs. If you do it well, if you do it properly, then it can be a great indicator of the bacteria, mostly group A. If you do it poorly, there's a whole lot of false negatives. Okay, there's a lot of errors associated with throat swabs, and a lot of the time they say that group A is a natural flora anyway, so they can show up even when they have it or not, so it's not that reliable. So just play it by ear. There is a criteria that we'll go through that indicates whether or not a swab should be done, and whether or not it's more likely to be bacteria related as well. There are tests out there these days that are antigen tests associated with group A. So if you work for an area that has those, that can be a nice, easy one to do, and should be done associated with the Centaur criteria that we're going to go through as well. Now, blood test is done for mononucleosis. It's a monospot, also a test associated with checking immunoglobulin M for the herpes virus Epstein-Barr. Okay, it has great sensitivity, obviously, because it's looking for exactly infectious state of mono, but it doesn't always show up in early days. If someone's only had these symptoms for 2 to 3 days, then the test can come back negative, and it's actually encouraged to redo the test in a couple of days' time as well, just to make sure. Last thing you'll investigate is obviously looking at the oropharynx itself. So looking in the throat, signs of pharyngitis is when it's viral, it's mostly you've got your real red, slight inflammation, but your tonsils aren't really inflamed. It looks irritated, it looks sore. A general viral infection can cause swelling of the uvula as well, and you're looking for that. If you have bacterial pharyngitis, then you will have those small areas, more likely anyway, the small areas of pustules forming itself, but it's mostly associated with having tonsillitis. Look at. So tonsillitis can be caused by mostly bacteria or viruses. When it's a virus, generally speaking, it is large in red. It looks like pharyngitis, but with enlarged tonsils. Okay, but when it's bacteria related, it's not a full coated tonsils. It's actually just small polyps of pus that you can see on the tonsils. Now, this can happen with viruses, and you can have a bacterial infection without the pus. So looking for it alone, again, so high fever alone, no good. tonsillar exudate by itself, no good. You need to build a criterion in order to rule in a bacterial infection. A grey furry tongue can be associated, but it's not always found in people, especially if people have good oral hygiene and they brush their tongue. You won't see this grey furriness, but it does happen in patients with that bacterial tonsillitis. When you see a mouth with Epstein-Barr, a lot of people mistake it for bacterial tonsillitis because they're looking for that cardinal sign of exudate from the tonsils. But Epstein-Barr will more likely have a large area of exudate as opposed to small pockets of polyps, and it almost looks like it has a glistening over the top of the tonsils. Okay, it's almost like a glazed donut effect over the top of the tonsils. And if I just turn everyone off donuts, then look at me helping the world. So when we're dealing with Epstein-Barr and you see something like this is when a blood test is really needed, because this can be bacterial tonsillitis or it can be Epstein-Barr. Okay, now whilst these pictures can be quite obvious, they can be quite subtle, and the cardinal signs that you look for can have a lot of overlapping features. With all three, pharyngitis, viral tonsillitis, and bacterial tonsillitis and Epstein-Barr, the overlap of symptoms can be immense, which is why we need to test for bacteria and test for viruses before giving treatment. Certain red flags we look out for when dealing with subjective and objective data is we looked at that persistent high fever. So if someone has a long-term high fever, it's something. It's a good enough infection to involve a lot of the macrophages to release pyrogen to give you a fever. Okay, so that is something. And if it's persistent, it means it's happening and the infection is probably getting worse. And all these infections can be associated with your sepsis as well. If someone's had antibiotics, they have these symptoms, and they're getting worse, then can have a resistant strain of bacteria, it's definitely a red flag. If you're dealing with children mostly, actually children solely for this one, if you're dealing with children, young ones mostly, and they rock up and they're complaining of a sore throat and they have drooling in the mouth, they have a lot of drooling, it's actually best, as hard as it is, it's easy enough to say, but as hard as it is you need to consider epiglottitis. And if it's epiglottitis, you do not examine the throat. Okay, you'll find the child will be drooling and they'll often extend their neck almost like a turtle in order to get in a breathing position where they can physically stay alive. And then clinicians will come along and they'll do a throat exam, get them to get in a position where they can see, open their mouth, and that can displace the epiglottis itself and actually cut the airway off. Okay, so it's quite dangerous. So just keep in the back of your mind, child, sore throat, drooling, extended neck, like a turtle, consider epiglottitis and don't examine the throat. If someone has quinsy, that's a high risk. That abscess can grow, can cut the airway off. Okay, so it's a high risk. And as mentioned, if you see candidiasis in adults, put your feelers up, start looking for early signs of diabetes, immunocompromise, things like that. Now, the assessment to denote whether or not it's group A strep or whether it's viral is we have a Centaur criterion. And this was invented a long time ago, and it's pretty good. Now, it's not 100%, but it gives us something to go for instead of our general feelings and assumptions based on pus and that sort of thing. So it's used as a means of ruling in whether or not we do a test, and also ruling in whether or not antibiotics are more likely to be considered than not. So if you have tonsillar exudate, then you get 1 point. If you have tender anterior cervical lymphadenopathy, then you get another point. Okay, so anterior lymphadenopathy that's tender on palpation, good to go. If they have a fever, or they have a history of a fever, then that's another point. And if they don't have a cough, then we're more likely to be moving away from those viral postnasal pharyngitis sort of problems more into those bacterial problems. Okay, so that's the 4 main points. And then everyone with a sore throat between the ages of 5 and 15 gets a bonus point just based on probability alone. And everybody who's over the age of 45 will get -1 point. okay, because they're less likely to have a bacterial infection than anybody else. And then we simply use, if they've got 1 to 0 of those, then they don't get any testing and they don't get any antibiotics. It's a virus, you treat it symptomatically. If they have 2 to 3, then you can warrant a test. You do a swab, you do an antigen test to see if it's bacterial. If they have 4 or more, then antibiotics is more likely the best course, and some organisations will actually say, don't bother testing, waste of time, just give empirical antibiotics. The way we work, that's our sign for a consultation. That's our sign to make a phone call and go from there. A lot of our protocols will be associated with giving antibiotics for tonsillitis with people that are really only high risk of your acute rheumatic fever. So if you believe it needs antibiotic treatment, because they can, make a phone call, go from there. Penicillins are often the first line to go for. Now, obviously, these are associated with bacteria, so look out for signs of your Epstein Barr. You'll have the tonsil exudate, you'll have the posterior chain, you'll have a fever, and you'll have an absence of a cough. Okay, so you can test, so just include that testing regime to be including that monospot blood test as well. And obviously, if you need that, they can't be in the field. All right, moving on with our treatment. Education is important. Most of the time, it's education around infectious. So even though Epstein-Barr is called the kissing disease, it's actually not considered that infectious, and you need to do a significant amount of kissing to get it. So talk to people about self-care. A lot of the good treatments include hydration, hygiene, and rest. Okay, and that's where a lot of the treatments will come in, and just educate the people on it. If the sore throat was caused by some sort of environmental factors, then include that in your education. Treatment, soothing fluid, either warm or cold, depending what the patient likes. Simple analgesia is great. Rest is amazing. The use of gargle and lozenges do absolutely nothing for the pathological state, but can be soothing. Okay, so whilst they have no treating properties whatsoever, it can be soothing, and the lignocaine-based gargles can obviously be quite nice for people with significant pain. Antibiotics only on consultation and only with positive Centaur criteria, or if the person is at risk of acute rheumatic fever. That's it. Okay, restrictions, play it by ear. If someone has Epstein-Barr, and that's the high index of suspicion, consider their job. If they're a crew commander, consider whether or not it's best for them to be commanding any crew, not because they're incompetent because of the virus, but if they take a large hit to the body armor associated with a jolt from the vehicle, then it can rupture the spleen. Also, contact sports, things like that. So restrictions around that is very important, and it can be important for 3 to 5 weeks after the infection is done. Okay, so splenomegalia can hang around for a while, and it puts the person at significant risk of internal bleeding. Okay, so always keep that one in the back of your mind. Days off work, working from home, resting, all those sort of things is great as well. As far as referral goes, we manage everything we can. If there's any red flags, it can be red flag because it's dangerous. It can mean we just need further investigation. So we'll always refer. And best to book in an appointment if someone has reoccurring tonsillitis. So generally speaking, it's 5 cases a year. Okay, but there can be circumstances, and every surgeon seems to have their own criterion. So if someone has reoccurring tonsillitis and they're starting to think that tonsillectomy is a good idea, book them in for an appointment. Okay, that ends the lesson on a sore throat. A little bit longer than the rest, but I was going to do a separate 5 lessons on each one of these disorders. But I figured people are going to rock up with a sore throat. They're not going to know what it is. And sometimes having a systematic approach of examining people can be a much better way of delivering information than looking at pathogens in isolation. So sore throat, you will see it. It can be quite mundane, can be coryzal, but can be all the way up to our quinsy and Epstein-Barr, which is life-threatening and can be a lifelong illness. So until next time, take care.